Hello, and welcome to Emerging Options for Elevated LDL Cholesterol, focus on PCSK9 inhibitors. I'm Dr. Deepak Bhatt from Brigham and Women's Hospital and Harvard Medical School. Before getting started, just a couple of housekeeping issues. First, a disclaimer and a disclosure of unlabeled use. Here are the learning objectives for this activity. So now let's get started. As you probably appreciate, there is a very high prevalence of elevated LDL cholesterol. Shown on this slide are some data from 2011-2012 for U.S. adults over 20 years of age, and the mean LDL cholesterol was approximately 115 milligrams per deciliter. That was compared with about 10 or so milligrams per deciliter higher in an older era, approximately a decade previously. The age-adjusted prevalence of high LDL cholesterol is 32.2%, and that compares with 42.9%, again, from a decade prior. So the prevalence is declining in some respects, most likely due to increased use of cholesterol-lowering medications. On this slide are shown some trends in high LDL cholesterol management in terms of percentages of patients treated in these two errors shown here, and the percentages controlled. However, despite some advances in the management of high LDL cholesterol, this remains a problem because the majority of patients in the U.S. are still uncontrolled, and in fact, I would say even those that are controlled, one might argue that a proportion are suboptimally controlled, since the targets for optimal therapy keep shifting and keep dropping. What exactly are the consequences of an elevated LDL cholesterol? This slide nicely summarizes the relationships between the number of risk factors, baseline cholesterol, and subsequent cardiovascular event rates. And here the cardiovascular events we're talking about are non-fatal myocardial infarction and stroke and coronary heart disease death. As you can see, there is a relationship between various degrees of cholesterol elevation and risk. Even in patients without cardiovascular disease, without diabetes, as the LDL cholesterol marches up from 70 to 130 to 190 milligrams per deciliter, there is an increase in risk of events over the next 5 years. When diabetes is added to the mix, that risk is further increased. And when coronary heart disease is added to the mix, that's the next row. Again, the risk is increased. And when both are present in the last row, the risk gets really quite high. So the combination of elevated LDL cholesterol, say 190, coronary heart disease, and diabetes, that's a 62% rate of a cardiovascular event over the next 5 years. So this really allows us to see the important relationship between cholesterol and other risk factors in cardiovascular risk. For sure, cholesterol elevation is a risk factor for cardiovascular disease, but it further amplifies other risk factors and is amplified by other risk factors with respect to subsequent cardiovascular risk. Fortunately, reducing LDL cholesterol improves cardiovascular outcomes. With respect to stroke, for example, there is a 4.5% decrease in the adjusted relative risk for stroke per 10 milligram per deciliter reduction in LDL cholesterol. Paralleling that, carotid atherosclerosis and its progression is also reduced with lowering of cholesterol, and non-fatal myocardial infarction is also lower when LDL cholesterol is lower. Let's move on now to a little bit of a discussion of the cholesterol guidelines and goals for therapy. Let's go back in time a little bit to the ATP3 guidelines and the 2004 update, which of course now is more than a decade old, but still interesting and informative to see what these guidelines had said. In patients at various level of risks, LDL cholesterol goals were set. And depending on what these goals were, consideration for drug therapy was also recommended. And you can see the relationships there with the added proviso that in patients who were very high risk, there was an optional goal of less than 70 milligrams per deciliter. So this is back in 2004, but we've gotten a lot of data since then. So in fact, these guidelines, especially with respect to that goal of less than 70 in very high-risk patients, was a bit ahead of its time and really quite right. And the goal in these guidelines was essentially to achieve a 30 to 40% reduction in LDL cholesterol levels in high-risk and moderately high-risk patients. Let's jump forward in time to the 2013 ACC-AHA guidelines. These guidelines identify 4 groups of individuals who are most likely to benefit from statin therapy. Those with clinical atherosclerotic cardiovascular disease, that's including acute coronary syndromes, history of MI, stable or unstable angina, coronary or other arterial revascularization, stroke, transient ischemic attack, or peripheral arterial disease, presumed to be of atherosclerotic origin. So basically, evidence of plaque in the coronary, brain, or peripheral circulation. For patients who don't have clinical ASCVD and who have an LDL cholesterol greater than or equal to 190 milligrams per deciliter, there again, statin therapy would be benefit. Those are folks that likely have some form of familial hypercholesterolemia. Typically, if we're talking about our adult populations, heterozygous familial hypercholesterolemia, and that should be treated. The next category of patients without clinical atherosclerotic cardiovascular disease, but who would benefit from being on statins, and the guidelines say to do it, are those aged 40 to 75 with diabetes, whose LDL is between 70 and 189. And then the final category of those without actual atherosclerosis that's documented who may benefit from statins are those aged 40 to 75 without diabetes and in that LDL range of 70 to 189, but who have an estimated 10-year risk for clinical disease of greater than or equal to 7.5%. The guidelines also say to consider treatment for a 5% to less than 7.5% risk, but there's a need for more detailed patient-physician discussion. Other considerations that the guidelines mention are that a healthy lifestyle should, of course, be encouraged in all individuals, that age, diabetes, and 10-year risk for clinical ASCVD influence the intensity of statin therapy, and in the case of intolerance to recommended intensity of statin, to use whatever the maximally tolerated intensity might be, as good common clinical sense would suggest, and that adherence to a healthy lifestyle and statin therapy should be monitored. This slide provides a summary of the guidelines and the algorithm that I more or less talked about. Green means treatment should be administered. Yellow means it's reasonable to administer treatment. And basically this is what I just said. If the patient has evident atherosclerotic cardiovascular disease, then they should be treated. Now, this flow chart says exactly how. If they're aged less than or equal to 75, it should be a high-intensity statin, though moderate intensity if for whatever reason they can't take or tolerate high intensity. But for those greater than age 75, the guidelines say that they should get a moderate intensity statin. That's a controversial recommendation. I'm not sure the data really support that, but at least that's what the version of the guidelines currently are saying. For patients as well whose LDL is greater than or equal to 190 milligrams per deciliter, as I mentioned before, they should be treated and with a high intensity statin, assuming it can be tolerated, if not moderate intensity. For the diabetic patients of the sort I mentioned, there it can be a moderate intensity statin, though if their atherosclerotic risk is high, their high-intensity statin might be considered. Again, a lot of this is rather controversial and debatable given the newest data, but again, this is just what the guidelines say. And then for that last cohort of primary prevention, where they haven't had any sort of evident atherosclerosis, don't have diabetes, LDL is not above that threshold of 190, there it comes back to what their atherosclerotic cardiovascular risk is and assessing it, and based on that a decision to go ahead and use either moderate or high intensity statin if their risk is greater than or equal to 7.5% and moderate intensity if it's between 5 and 7.5%. So good general guidance of probably what the minimum levels of therapy should be. The 2014 National Lipid Association guidelines are actually very clear and easy to use, and I'm going to just say a couple of things about them. There are two parts. Part one covers the core principles of management where there's high quality evidence, but part two covers areas where there may not be as much robust evidence, but where still you've got to do what you've got to do for the patient in front of you. And part one is summarized on this slide. If the patient's very high risk, the LDL goal is less than 70, and drug therapy should be considered if they're above that. So that very high risk includes patients with atherosclerotic cardiovascular disease and also patients with diabetes with 2 or more risk factors or with evidence of end organ damage. So I would agree that's a very good set of guidance for 2014 in particular. High risk includes 3 or more major atherosclerotic cardiovascular disease risk factors, or diabetes, and less than or equal to 1 risk factor, or advanced chronic kidney disease, or an LDL cholesterol greater than or equal to 190, or just risk scoring that takes a patient to high risk. And there the goal is less than 100. Again, therapy gets started if above 100. For moderate risk patients, you see the goals there, as well as low risk or less than 100, but the threshold to initiate drug therapy is a little bit different, 130 and 160 respectively for moderate and low risk. So a very rational set of guidelines. There are other guidelines out there as well, the European guidelines, the Canadian guidelines, that more or less are pretty similar to the 2014 NLA guidelines. So let's move now to a discussion about LDL cholesterol lowering and why to do it. Well, the reason to do it is because lower does seem to be better with respect to the risk of cardiovascular disease. And it is the absolute level, not the percent of LDL cholesterol reduction, that defines the risk for cardiovascular disease in the minds, at least, of some experts. But, and I'm really talking now about what defines the level of actual risk, not so much what to do with therapy. And the risk of cardiovascular events is clearly lower at very low levels of LDL cholesterol than at moderately low levels. So 75 to 100 is better than over 100. Less than 50 seems to be better than just 75 to 100. But it's important to realize that these data, when we're talking about pharmacological lowering, have to do with achieved LDL cholesterol levels, which is a combination of lifestyle, drug, and importantly, adherence to drug or drugs. So it's a bit of a confounded relationship. Now, part of it is almost certainly causal, that is, drugs that lower the cholesterol to lower levels are associated in general with cardiovascular benefit. But part of it might also be that on a given regimen, a patient that achieves a lower LDL cholesterol is more adherent to that medicine, and it's actually that adherence and the other things, the other good things that go with adherence that also in part accounts for their better cardiovascular outcomes. So a little bit hard just to tease out whether the achieved LDL per se should be a target LDL. But in general, the epidemiology data, the pharmacotherapy trial data, all are reasonably consistent, showing that lower is better. This slide summarizes that concept with the randomized clinical trials showing that reductions in LDL cholesterol are associated with reductions in cardiovascular events in a way that's almost linear, at least within the range of cholesterol that's been well studied. So indeed, so far, it does appear that lower is better. And greater reduction in LDL cholesterol levels, that is higher percentage reductions, seems to be associated with greater reduction in major cardiovascular disease event rates. Now, there have been a lot of trials in terms of statins, both at this point in time, both for primary and secondary prevention. And there certainly appears to be a lower cardiovascular disease risk and event rate at lower levels of LDL cholesterol. The CVD risk reduction depends not only on the amount of LDL reduction, but also on duration of therapy. In some of the trials, in particular low-risk patients, there's a bit of a lag effect before the curves start to diverge and treatment benefit is evident. In some of the higher risk trials, ACS-type patients, there the benefits seem to occur even sooner. The evidence probably most would say is insufficient to set specific LDL cholesterol treatment goals for both primary and secondary prevention. Similar statins and their doses were used in primary and secondary prevention trials, and statin intensity directly was associated with greater benefit, in particular in secondary prevention. So we have a general sense that lower is better, but exactly what the numbers should be, what the target should be, is a matter of great ongoing debate. So let's quickly review some of the key trials, such as the Prove It TIMI 22 study. And this was a trial that was comparing in patients with recent acute coronary syndromes a moderate statin approach, pravastatin 40 milligrams daily, to an intensive statin approach, atorvastatin 80 milligrams daily, with a mean follow-up of 24 months. So reasonable study duration, well-designed trial. And in terms of LDL cholesterol, in the pravastatin arm, the medians dropped from 106 at baseline to 95. In the atorvastatin arm, it dropped from 106 to 62. So basically, it's actually a comparison of different doses of different drugs, atorvastatin versus pravastatin. But there are, of course, different achieved LDL levels, 95 versus 62. Or just to keep it all straight in my head, I like to think it was 90 versus 60. So going to that level of LDL cholesterol reduction, one was hoping would have greater benefit. And indeed, that was the case. The primary endpoint of this trial, which was death from any cause, MI, documented unstable angina requiring hospitalization, revascularization performed at least 30 days after randomization, and stroke, that composite endpoint was lower in the intense group, that is the atorvastatin group, 2 years, and the event rates for atorvastatin were correspondingly 26.3% versus 22.4%. And that 16% reduction in the hazard ratio favored atorvastatin, very significant finding. The discontinuation rates for pravastatin and atorvastatin were 33% versus 30% at 2 years. So really no significant difference, and certainly wasn't worse for atorvastatin. So overall, really powerful data supporting the benefit of a more intense regimen in ACS patients. Now, what actually happened to patients in that atorvastatin arm? I just showed you the mean levels of LDL cholesterol achieved, around 60-ish, but a proportion of patients didn't have such a great reduction, and some had a really whopping reduction, getting less than 40 milligrams per deciliter and 11%. So there were data on what was actually achieved in the trial. As it turns out, those patients that achieved a lower LDL cholesterol level had lower rates of cardiovascular events, which strongly suggests that lower is better. Now, it's still different than doing a randomized clinical trial and saying, I'm going to target you to 80 to 100 versus less than or equal to 40. Patients weren't randomized to strategies of LDL targets, but rather to 2 different doses of 2 different drugs, an intense versus a moderate strategy. So we can't say that the observations on this slide necessarily should point to what the target LDL should be, but it is strongly suggestive. Let me move on now to a primary prevention type trial, the Jupiter trial. And this was to see if statins would be useful in patients that had an elevated high-sensitivity C-reactive protein, but not out-of-control cholesterol. So patients had to have an LDL cholesterol less than 130, high-sensitivity C-reactive protein greater than 2 milligrams, greater than or equal to 2 milligrams per liter, and then they were randomized to rosuvastatin 20 milligrams or placebo. The trial was a large study with about 8,900 patients in each arm, with a median follow-up of a little under 2 years. And with respect to cholesterol achieved, it started off at a median of 108, and placebo was basically unchanged at 109. But in the rosuvastatin arm, dropped from 108 to 55. So a 50-ish% reduction in LDL cholesterol levels on average in the population with rosuvastatin at 12 months. So that shows the degree of LDL reduction that can be achieved with this dose of rosuvastatin, pretty good degree of LDL reduction. And this LDL reduction translated into a reduction in the rate of the primary endpoint of non-fatal MI, non-fatal stroke, hospitalization for unstable angina, arterial revascularization, or confirmed death from cardiovascular causes. So the hazard ratio was 0.56, so about a 50% reduction, very statistically significant. And included in this was a reduction in all-cause mortality that was significant. As far as adverse events go, the rate of overall adverse events was quite comparable. One notable difference was physician-reported new onset diabetes, which was more common with rosuvastatin, 3% versus 2.4% with placebo, p-value of 0.01. So small difference, but statistically significant, and has been reproduced in other analyses of high-intensity statin regimens. So the price to pay for a high-intensity statin is a slight, but what appears to be real diagnosis of diabetes that is more likely. I think it's important to put this in perspective, though. The increase is small, and in the context of drugs that are reducing important ischemic events, and in some populations and trials, even all-cause mortality, I think this small risk is acceptable, though something that we need to keep an eye on in future trials and even in ongoing trials and in our own patients, something that we need to be mindful of, that is, be vigilant for the development of metabolic syndrome and diabetes. Now, of course, in this hypolipidemic population or primary prevention population, in general, primary care physicians would be screening for diabetes, but important just to be vigilant for that potential side effect. Well, let's move on now to a relatively recent trial, the IMPROVE-IT trial. This came out in 2015, and the goal was to take patients with a recent acute coronary syndrome with an LDL cholesterol of between 50 and 100 if on lipid-lowering therapy, or between 50 and 125 if not on lipid-lowering therapy. And these patients were randomized to simvastatin plus ezetimibe or simvastatin plus placebo, and the simvastatin dose was 40 milligrams, the ezetimibe dose was 10 milligrams. So basically, it's ezetimibe versus placebo on the background of a good statin. The median follow-up was 6 years in each arm. And here are the LDL cholesterol levels. The simvastatin-only arm went from 93.8 to 69.9, or I like to think just from 90 to 70. And the simvastatin plus ezetimibe arm essentially went, again, the same baseline value from 90 to 50. I like to think of it just to round things off and keep the numbers easy to keep track of. So a difference really between 70 and 50 in terms of the achieved LDL cholesterol. Did this matter? Did this modest difference in cholesterol translate into improved outcomes? Yes, indeed it did. The primary endpoint of death from cardiovascular disease, non-fatal myocardial infarction, documented unstable angina requiring hospital admission, or coronary revascularization greater than or equal to 30 days after randomization, or non-fatal stroke, that primary endpoint, that composite endpoint, was lowered with the combination therapy at 7 years with rates of 32.7% versus 34.7% respectively for the in favor of the ezetimibe arm. So that worked out to a hazard ratio of 0.94. And that was a significant finding. Really similar safety in the two groups, so no real issue there with safety concerns. There had previously been some issues raised about ezetimibe causing cancer, but in this long-term study, no hint of that. So further evidence that lower is better, but now with a non-statin compound, with ezetimibe. So despite all the good data for statins, the reality is that patients remain undertreated with statins. These are some data from the International REACH Registry of patients with atherosclerosis or multiple risk factors for atherosclerosis, showing a fair amount of undertreatment with respect to statin therapy or lipid-lowering therapy in general. This is true in coronary artery disease, it's true in peripheral artery disease, it was true in cerebrovascular disease. It was true in all the geographic regions we examined, North America as well as other parts of the world. And it was also true across different physician specialties, that is general practice, neurology, cardiology. Of course, there was some variation, but overall, even the best rates by region or physician specialty were lower than optimal. Again, in the REACH registry, here are some more data showing the percentage of statin use. Shown are the rates for patients with prior ischemic events, with stable atherosclerosis without a prior ischemic event, and with risk factors only. And across the board, there's just a lower rate of statin use. And even though it could be a cup is half full sort of way of looking at it, that is, the majority of patients were treated, clearly these rates are not ideal. And they didn't improve over the time of the study, at least not to the degree that we would have liked given all the emerging data. Shown here is a meta-analysis of statin trials. It shows that 40% of patients on high-dose statin failed to reach an LDL cholesterol less than 70, despite the fact that lower LDL cholesterol levels are associated with a lower risk of cardiovascular events. This analysis showed, interestingly, that the risk of major cardiovascular events was lower even at very low levels of LDL cholesterol, more so than moderately low levels, say less than 50 versus in the 70 to 100 range. So an interesting way of summating all the data. And that doesn't even include the most recent data. So why is it that patients might not use or use but not benefit from statins? Well, here's some potential reasons for lack of statin benefit. Familial hypercholesterolemia with high LDL cholesterol, intolerance to high statin doses, or high cardiovascular risk and failure to achieve target LDL cholesterol levels in patients who are already on high-intensity statin, and now I'd say even including ezetimibe in the mix. But patients who are still at high cardiovascular risk and still have LDL cholesterol levels that are suboptimal are ones who aren't really deriving full cardiovascular protection and might need more. So let me first talk about familial hypercholesterolemia. This is, as I'm sure you know, a genetic disorder. It's characterized by very high levels of LDL cholesterol due to decreased LDL cholesterol clearance from the plasma. It leads to premature coronary heart disease. The severity of symptoms varies. It depends on the extent and the exact type of genetic mutations. The diagnosis can be made on the basis of clinical, biochemical, and if one chose genetic criteria. Traditional management's been statin and lifestyle measures, and I'm really talking about familial heterozygous hypercholesterolemia here. And most cases are undetected, or they're treated but sort of accidentally treated. That is, their cholesterol is noted to be high, the patient's treated, but it's not really appreciated they have familial hypercholesterolemia and they end up being treated inadequately. A little bit about the genetics. It's the most common monogenetic disorder of lipid metabolism. It's estimated to be at least about 1 in 500 individuals or so in the general population. Of course, it depends on the exact population. In some can be as high as about 1 in 250. It's an autosomal codominant mode of inheritance. Heterozygous parents have a 50% chance of passing it on to their offspring. In heterozygous FH, the LDL increases to about as high as 216 milligrams per deciliter. In homozygous FH, the LDL cholesterol increases even beyond that range. With homozygous FH, if you've ever seen it, the cholesterol levels can be really extraordinarily high. The mutations that can cause it, these are some of the ones that are listed: mutations in the LDL receptor, the ApoB gene, a gene for PCSK9. This slide shows the mechanism of action of PCSK9 and then ultimately the basis of PCSK9 inhibitors. And the biology is really pretty elegant, and just for the sake of time, I'm not going to go through all the science of it, but really fascinating that, of course, LDL receptors are there on the cell membrane binding to LDL cholesterol, but PCSK9 can also bind to LDL receptors, ultimately leading to their degradation. And if one blocks that PCSK9 with a PCSK9 inhibitor, it allows LDL receptor recycling, hence more clearance of LDL particles from the bloodstream. So that is a sort of PCSK9 101 version of what's actually pretty sophisticated and pretty complex. And it turns out the concentrations of PCSK9 and LDL cholesterol correlate rather positively. As far as PCSK9 mutations go, there are gain-of-function mutations that result in high LDL cholesterol levels. We think that those are bad. And one example of a SNP is listed here that's linked to increased LDL cholesterol levels. And if the patient has the minor allele and is a homozygote, the LDL cholesterol levels can be 89. If they are heterozygotes, then they can be 146, and for major allele homozygotes, it could be 161 in terms of the increased level of LDL cholesterol. So you can see there the influence, a bit of a dose response as you'd expect. So really showing how gain of function can increase cholesterol by pretty sizable amounts, especially if you think about this as a lifetime increase in lifetime exposure. Much like their gain of function, there can also be a loss of function by any variety of mechanisms, including nonsense mutations in the PCSK9 gene, and the loss of function results in low LDL cholesterol levels. And in the relatively small number of patients or people that have been seen with these, they appear to have a markedly reduced risk of developing atherosclerosis and its complications, realizing, of course, there aren't very many patients that have been studied that fall into those extremes, but that number is growing. So let me talk now about PCSK9 inhibitors. There are a number of different agents that are out there in use, under study. The two listed at the top are human monoclonal antibodies, alirocumab and evolocumab. These have been approved by the US FDA. There are other compounds that are monoclonal antibodies, as you can see listed in phase 2 and phase 3 trials. And then there are other types of compounds as well, siRNA oligonucleotides, antisense oligonucleotides, that are in very early stages of testing. So there is a lot that will be coming out in terms of science and clinical trial data in the field, but right now there are already 2 approved injectable monoclonal antibodies. Let me review now the alirocumab studies, and this is one of the 2 approved PCSK9 inhibitors. There have been a lot of studies, and for the sake of time, I'm not going to go through every single detail about each one, because there are certain themes that emerge that I think are more important to know and understand than necessarily knowing every detail of each trial. But as part of the Odyssey program, alirocumab was extensively studied with respect to its effect on lipid parameters. And these studies, as you can see on the right-hand column, for the most part had intensive statin therapy as the background therapy. In one case, Odyssey Alternative, that wasn't so. And the control arms were in many cases placebo, and in some cases ezetimibe 10 milligrams. The populations studied are listed in that third column. In the case of some of these studies, it was familial hypercholesterolemia, and in other ones, it was just plain old hypercholesterolemia. Continuing the list of different studies that are out there, again, you can see various control arms, placebo or ezetimibe, various degrees here of background statin therapy intensive, in some cases none, in some cases not so intensive statin therapy. So a range of different background therapies in the 2 treatment arms. And again, a variety of different patient populations being studied, largely familial hypercholesterolemia or just plain old hypercholesterolemia. So those are the alirocumab studies. The evolocumab studies are pretty similar in terms of the characteristics I just described. Again, their acronyms are listed, and there's a theme here of different names that you can probably see: Descartes, Gauss, Laplace, Mendel. And these different trials had, in some cases, intensive statin therapy as background, in other cases non-intensive statin therapy, in some cases none, and the control arms again ranged from a placebo to ezetimibe 10 milligrams. The population studied included those with hypercholesterolemia, those patients who were statin intolerant, and also patients who were having various degrees of FH. This slide just continues really what I was just saying again, now adding the Rutherford, Tesla, and Yukawa and Mendel 2 studies, variations on the theme, similar sorts of populations covered where there's intensive background statin therapy in both arms or no statin therapy and controls of placebo and ezetimibe, and again FH, heterozygous, homozygous FH and Tesla, and just plain old hypercholesterolemia studied in these various trials. Again, I don't know that I would spend a lot of your energy trying to figure out which trial was which specific population. It's hard to keep track of, and there are lots of nice review articles, some of which are referenced here, if you really wanted to go back for that level of detail. But from a clinician's perspective, here's the bottom line. First, for alirocumab, as you can see in these various studies, significant reductions in LDL cholesterol. There also are reductions in other important parameters like ApoB, non-HDL cholesterol, triglycerides, and some improvements in HDL cholesterol, and perhaps importantly, some reductions, significant reductions in Lp(a), which at least according to some experts and in some studies seems to be a bad player and a marker of cardiovascular risk. But at any rate, primarily significant reductions in LDL cholesterol in all these different populations that were studied. I should point out when I'm talking about these LDL reductions in this and subsequent slides that the effective treatment shown here is a change from baseline and adjusted for the specific comparator arm. Now, let me just show you the evolocumab summary, and it's really very consistent with alirocumab, where those same parameters I just mentioned are influenced in the same way. Particularly notable, again, are reductions in LDL cholesterol. That's the main goal of these studies, but also nice to see reductions in ApoB and Lp(a), and perhaps that latter mechanism of action will translate into some meaningful clinical benefit, but we'll have to see with different ongoing trials. And here, just continuing the evolocumab, really more variations on the theme, significant reductions in LDL cholesterol, in most cases exceeding 50% reduction. So that's what happens on LDL, large, impressive reductions in LDL across wide ranges of populations seen for now two different drugs in the same class, PCSK9 inhibitors, specifically alirocumab and evolocumab. Does any of this translate into reductions in clinical events? That's the question everyone, of course, asks. And the answer is, well, outcome trials are ongoing. There aren't any completed outcome trials to date. However, of the trials that have been done, that have been designed to look at LDL cholesterol and other biochemical parameters, of course, adverse events were recorded and mortality was recorded. And if you pull all the trials that have been done to date, again, these are trials designed to look for cholesterol reduction. But if you do just pull the mortality data, it's a small number of events, as you can see overall. But pulling it, interestingly, provocatively, reassuringly, there is a reduction in all-cause mortality that's seen, an odds ratio of 0.45. So, you know, about a 50+% reduction in LDL cholesterol and about a 50-ish% lower mortality. But again, while this is very scientifically exciting, it's important to be extremely cautious about these data. The number of events is extremely low, and these trials weren't designed to look at cardiovascular outcomes. But at any rate, This is what mortality shows in the meta-analysis. Similarly, CV mortality is directionally reduced, not quite statistically significantly, but directionally reduced by 50%. The rate of MI reduced by 50%, significantly so. The rates of unstable angina, the p-value wasn't significant, but really a low number of events, and the hazard ratio, or the odds ratio to be precise, is going in the right direction, but clearly not statistically significant. Well, what about CK levels? Do PCSK9 inhibitors increase CK levels? Well, to date, as you can see from this meta-analysis, most of the studies have not found that. In pulling the data together, there does not appear to be an increase in CK levels with PCSK9 inhibition. What about just the effect of this new class of drugs, this injectable class of drugs, on serious adverse events? Of course, SAEs, or serious adverse events, are captured in all clinical trials, and the odds ratio is 1. So at least in the context of carefully selected, relatively healthy patients entering lipid-lowering trials, there was no significant difference in the rate of SAE. So that's very reassuring, realizing that the duration of follow-up here in these studies, for the most part, is relatively short, so we do need a larger number of patients, longer-term studies to make sure these drugs are as safe as they appear to be based on the limited number of patients to date. Let me now discuss a couple of the studies. Again, the aim here was really to look at the safety of these drugs and their efficacy on LDL reduction. But this is the Odyssey long-term trial. It is a trial of high-risk cardiovascular event patients, LDL cholesterol of greater than or equal to 70, who are on a statin at a maximally tolerated dose. And they can be on other lipid-lowering therapy in some cases and not in others. But these patients were randomized to alirocumab, 150 milligrams subcutaneously every 2 weeks, or to placebo. The treatment duration was 78 weeks in each arm, and outcomes were assessed at week 24 in each arm. So the LDL cholesterol at 24 weeks was lower in the alirocumab trial. I basically had showed you that data before. The mean percentage change from baseline was approximately 60-ish%. The LDL cholesterol remained low over that full 78-week period that I mentioned, but these numbers are from 24 weeks. And the actual numbers are a reduction in the alirocumab arm from 122 milligrams per deciliter to 48 milligrams per deciliter, hence the 60-ish% reduction. So very large reduction in LDL cholesterol, and of course in placebo, there's no change over that period of time. Now, the interesting part of the study, and I showed you the meta-analysis, but now we're talking about an individual study program here. The rate of major adverse cardiovascular events was also lower with the PCSK9 inhibitor, alirocumab, versus placebo, 1.7% versus 3.3%. That's a hazard ratio of 0.52. So again, about a 50-ish% lower rate of cardiovascular events. And this was in the context of any adverse event being similar between the two groups. So a very interesting signal of potential cardiovascular benefit. Event rates were low, the number of events were low, follow-up duration is not particularly long in the context of cardiovascular outcome trials. So need to be really cautious about embracing these outcome data prematurely. But this early signal of cardiovascular efficacy does look good. Let me move on now to the OSLER program, and here the patients were in one of the trials I mentioned of evolocumab, and therefore randomized to evolocumab plus standard therapy versus standard therapy alone. The sample size overall is a bit over 4,000 patients. The median follow-up was 11 months in each arm. And again, LDL is lower by about 60-ish% at 12 weeks with evolocumab, so remarkably similar to what was seen with alirocumab. But now it's important to realize beyond just the LDL reductions at 12 weeks, the sustained reduction over 48 weeks, again, an impact on cardiovascular outcomes. CV events at a year was lower in the evolocumab group versus the standard group. 0.95% versus 2.18%, or 1 versus 2%, so a hazard ratio of 0.47. So again, about a 50-ish% reduction in this separate trial program with a separate compound, a related PCSK9 injectable compound, but still a different drug in the same class. And again, the rate of adverse events was similar between the two arms. So very reassuring early data with both these PCSK9 inhibitors. But I'll say it again with the major caveat that these trials were not designed, not powered to look at cardiovascular outcomes. So we really do need to see what the dedicated cardiovascular outcome trials show before assuming that LDL reduction from these potent compounds is translating into cardiovascular benefit. But it sure is exciting and I think a promising early signal to see these lower event rates. In terms of ongoing trials, let me start with alirocumab. Odyssey Outcomes is ongoing. It's a study of alirocumab versus placebo in patients with acute coronary syndromes. The target completion dates listed there. It's hard to know with these trials exactly when they're going to be reported out. In many cases, the trials are event-driven, so it depends how quickly the trials enroll, when the events accrue. So the target completion dates really are estimates from clinicaltrials.gov that are listed here, and it remains to be seen when these trials really report. Here's a table now with evolocumab. The Glagov study is ongoing, examining patients with coronary heart disease and an indication for coronary catheterization to see what the effect is on progression of atherosclerosis. The large outcome trial is Fourier, examining evolocumab versus placebo, obviously on a background of statins, in patients who are who have clinical cardiovascular disease or at high risk of recurrence. And then Tausig is also ongoing. This is specifically of patients with homozygous familial hypercholesterolemia or PCSK9 mutations with elevated LDL cholesterol levels or receiving apheresis. So a nice development program, and between these two different compounds, we'll have lots of patients who've been in outcome studies. There's another compound that I showed a few slides back that's a bit earlier in its development and is not currently FDA approved or available. It's bococizumab. And again, it's also an injectable PCSK9 inhibitor, subcutaneously injected, and it is being studied in the SPIRE program, a number of SPIRE trials looking at patients at various degrees of risk and with various degrees of LDL elevation. So it'll be nice to see if this program as well finds concordant reductions in not only lipid parameters, I'm sure that will be the case, but also if there is some reduction in cardiovascular events. And shown here are, in fact, the outcome trials for bococizumab, the SPIRE-1 and SPIRE-2, and those trials are ongoing, and we'll see again when they report what the definitive effect is on cardiovascular outcomes with this compound. Now let me just mention some of the completed phase 3 trials, in this case for alirocumab with Odyssey Alternative. That was in patients randomized to alirocumab versus ezetimibe and alirocumab versus atorvastatin. And it was patients with statin intolerance who had primary hypercholesterolemia and moderate high or very high cardiovascular disease risk. It's, I think, a fascinating trial beyond just the drug aspect of it studying a novel drug, just studying the statin intolerant population. And it's interesting because there definitely are patients who are statin intolerant, but other studies have shown us as well that there are patients who also are statin intolerant, but you can even put them on placebo, and they are having quote-unquote statin intolerance. So very challenging population because some of it is not related to the drug, and some of it actually is related to the specific drug and sometimes to the class of drugs. So a lot of work going on out there on statin intolerance, and we need to learn a lot more about it. Odyssey FH1, also looking at alirocumab, examined heterozygous familial hypercholesterolemia. Odyssey FH2 also examined heterozygous familial hypercholesterolemia, but with a little bit of a different comparator with respect to statin. And, you know, these trials, at least at the time that I'm doing this presentation, aren't published, but the preliminary results have been presented. So, you know, we'll see what the exact findings are. But in terms of LDL reduction, there were significant reductions in LDL. A couple of other trials, just to mention, in terms of completed trials with alirocumab, there's Odyssey Options 1, Odyssey Options 2, and these are all really variations on the theme, different background comparator lipid cocktails in patients with hypercholesterolemia and high cardiovascular risk, but in whom their hypercholesterolemia is not well controlled. And again, you know, these aren't published, but the preliminary results have been presented and really consistent findings of LDL reduction across the board. So what is the actual prescribing information in the U.S. per the FDA labeling? That's shown here with the links as well for anyone that wants to go into greater detail. So for alirocumab, it is indicated as an adjunct to diet and maximally tolerated statin therapy for the treatment of adults with heterozygous familial hypercholesterolemia or clinical atherosclerotic cardiovascular disease who require additional lowering of LDL cholesterol. And it is recommended at a starting dose of 75 milligrams subcutaneously every 2 weeks. If the LDL cholesterol response is inadequate, then the dosage can be increased to 150 milligrams every 2 weeks. So that's alirocumab. Evolocumab, also indicated as an adjunct to diet and maximally tolerated statin therapy for adults with heterozygous familial hypercholesterolemia or with clinical atherosclerotic cardiovascular disease who require additional lowering of LDL cholesterol. I should also mention it is indicated for patients with homozygous familial hypercholesterolemia who require additional lowering of LDL cholesterol. So that's one slight difference between the two, the inclusion specifically of homozygous FH in the evolocumab label. And the dosing administration is as follows for primary hyperlipidemia with established clinical atherosclerotic cardiovascular disease or heterozygous familial hypercholesterolemia. The dose is 140 milligrams every 2 weeks or 420 milligrams once monthly. For homozygous FH, it's 420 milligrams once a month. Just a practical point: to administer 420 milligrams, give 3 injections consecutively within 30 minutes. And to emphasize, these are subcutaneous routes of administration. To date, patients have, at least from what I've seen, tolerated these sub-Q injections pretty well. There are auto-injectors that do it, and it seems to be very well tolerated by patients. There is a slight increase in cutaneous site injection reactions versus obviously not getting the injections, but still overall appear to be very well tolerated. As far as how these are supplied with alirocumab, it's supplied as either a 75 mg per ml or 150 mg per ml solution in a single dose pre-filled pen or single dose pre-filled syringe. The evolocumab's in 140 mg per ml in a single-use pre-filled syringe or a single-use proprietary auto-injector. So again, if you want to get to the 420, that would be 3 injections of that. As far as the storage and handling, the details are listed here. You can review that at your leisure. There are some things to be aware of in terms of how to store them and refrigeration and issues like that. So if you're involved with that aspect of the drugs, make sure you're familiar. Other things in the prescribing information: most commonly occurring adverse reactions defined as greater than or equal to 5% in treated patients and occurring more frequently than placebo, though not necessarily statistically significantly more frequently. But what's listed in the label is nasopharyngitis, injection site reactions, and influenza with alirocumab, and with evolocumab, nasopharyngitis, upper respiratory tract infections, influenza, back pain, and injection site reactions. And of all of these, really the one that most commonly is occurring and causally related to the drug would be the injection site reactions. So potential theoretical safety concerns that had been raised with the possibility of patients achieving very low LDL cholesterol levels with these drugs were, might it interfere with vitamin E synthesis, might it hurt steroid hormones, gonadal hormonogenesis, and just really do bad things through those mechanisms. Well, as it turns out, there's no evidence supporting these concerns. Recent one-year data from Descartes suggested no effect on vitamin E, no adverse effect on vitamin E or steroid hormone formation. So at least with a reasonably large number of patients, careful study in Descartes, we don't see this, with the one caveat that those were one-year data. But for these particular parameters, likely we would have seen something even by a year. What about issues of cost? That's a real issue. The annual wholesale prices are listed here for the U.S. around $14,000+. And in terms of whether this is cost effective or not, there have been a couple of different analyses out there. One is listed here from the Institute for Clinical and Economic Review, and they suggested that to achieve cost effectiveness, the price would need to be reduced substantially. And similarly, that report suggests to avoid cost burden to the U.S. healthcare, the price needs to be reduced. Now, obviously, that's out of the control probably of anyone that is listening to this and actually taking care of patients. So, we've got to figure out how to bring these therapies to the patients that are most likely to benefit, but at the same time try to be careful stewards of the collective healthcare dollars that are out there. So how then might PCSK9 inhibitors be integrated into clinical practice? Well, potential populations in which to consider these agents include patients with familial hypercholesterolemia and high LDL cholesterol, patients who are intolerant to maximal statin doses, and patients with high cardiovascular risk who fail to achieve target LDL cholesterol levels on high-intensity statins or high-intensity statin plus ezetimibe as well. And these are patients in whom to consider the use of PCSK9 inhibition if they're, especially if they're at high cardiovascular risk. So to conclude then, LDL cholesterol is a potent risk factor for cardiovascular disease, although it remains suboptimally treated, especially as we start recommending goals that are lower and lower based on randomized clinical trial data. This undertreatment is particularly true in familial hypercholesterolemia, which is just pretty under-recognized, and I'm talking especially about heterozygous FH. Also, undertreatment is an issue in statin-intolerant patients because other than ezetimibe, there have been limited sorts of evidence-based options other than going back a bit in time. And in patients who are at very high cardiovascular risk, those are patients where LDL also is undertreated, and that is corroborated by some of the registry data I showed you and other registry data that I didn't show you, including very contemporary data. Statins clearly reduce cardiovascular risk across a broad range of baseline cardiovascular risk, so that's an important point. They reduce risk in ACS patients, in lower risk secondary prevention, and even lower risk primary prevention patients, such as those in Jupiter with an elevated CRP. So this reduction in clinical events with statins seems to be true across a variety of levels of baseline risk strata, and also across a variety of baseline LDL cholesterol levels. And the latest cardiovascular outcome data, as I mentioned with IMPROVE-IT, also support the role of ezetimibe when added to statins. The PCSK9 inhibitors, finally, are potent LDL cholesterol lowering drugs. But these ongoing clinical trials will be very important to determine their effects on cardiovascular outcomes. There's no question that the PCSK9 inhibitors lower LDL cholesterol and also seem to lower some other biochemical parameters that might be useful, such as LP little a. But we really need to see what the ongoing cardiovascular outcome trials show before deciding that this LDL reduction is definitively reducing cardiovascular risk. The early signals certainly suggest that it does, but we do need larger number of patients from longer-term trials to make sure that the LDL reduction mediated by PCSK9 inhibition indeed does translate into cardiovascular risk reduction, but also to make sure that there aren't some unexpected safety signals that emerge. I talked about the steroidogenesis that doesn't seem to be affected, but some have raised concerns about issues like diabetes, and to date, that doesn't seem to be a concern, with new onset diabetes being an issue with PCSK9 inhibitors. Other issues that have been raised have to do with subtle effects on neurocognitive function, and part of the ongoing evaluation of these agents includes long-term studies looking for subtle changes in neurocognitive function. But to date, the safety data look very reassuring, and how to integrate these agents into clinical practice, I think, will really depend on the specific risk profile of the patients in front of you, as well as what the evolving data show. Well, thank you very much for your attention. I hope this review of what has been going on in the lipid-lowering field lately and what had preceded it was useful and educational. Thank you so much for your attention.